Morning, everyone. Thank you, Rohaida, for your kind introduction. First of all, I would like to thank all of you for spending your wonderful morning on a Saturday with us today to and join us to learn more about living well with epilepsy. We are into our third year of this public awareness campaign. The first year was also a webinar and it was well received. Last year, it was a public roadshow that is actually, we have also received good feedback as well. So at SingHealth and NNI, we are united by our common purpose of to put patients at the heart of all we do, and therefore we are constantly thinking about how we can improve care for our patients, be it medically or psychosocially, and also in the community as well. So for this public webinar or public awareness campaign is just one of our many various efforts in trying to reach out to our patients in the community and in the society. Just for example, we have given Marina Bay Sands hiring director a talk about inclusive employment and job safety placement as well in their job place for patients with epilepsy. So we have also worked with our community partners who will also share their experience with us later on from Minds with regards to their experience in terms of caring for patients with epilepsy. So as you can see, there are many various efforts in trying to support the patients and persons with epilepsy in the community. And today's topic, our team today, Living Well with Epilepsy, is to focus on the psychosocial part of management of our patients with epilepsy. And therefore, we also have the honor to have our psychologists from NNI to share their experience with us as well. So this is going to be we have a few talks lined up for everyone, so I'm not going to delay any further, but hopefully everyone will learn something from today's talk. Thank you.
Thank you, Dr. Chiu. Okay, so we shall now start the program rolling and invite our first speaker, Dr. Kong Yong Yao. Dr. Kong Yong Yao is a consultant neurologist at the National Neuroscience Institute with a special interest in epilepsy. He graduated from Monash University with honors and completed his specialty training in internal medicine and neurology at the National Healthcare Group and SingHealth residency programs. He will be sharing with us the topic, Epilepsy, a Simple Part of a Normal Life. Dr. Kong, please.
Hi, everyone. Thanks once again for being here this morning. I'm very glad that everybody's here today, and hopefully at the end of this talk, I can demystify some of the more confusing parts of epilepsy, and I hope everyone learned something today. Okay, so here we go. Okay. Excellent. Okay, so this is what we will talk about today in very simple terms. First of all, I'm going to try to give everybody an understanding of what seizures are in epilepsy. I'll go through some of the definitions and also hopefully elucidate some of the mechanics of how seizures occur. Then I'm going to talk to you about how doctors think, hopefully give you a peek behind the curtain so that you understand what your doctor is trying to do or say when they order certain tests or give you certain types of treatment. And this might make the clinic consult sessions or the time where you speak with your doctor on the wards a bit clearer. Your experience speaking to your doctor is a bit clearer. Then I'm going to talk a little bit about living with epilepsy. I'm fully aware that being epilepsy patients, a lot of you probably have a much more intimate understanding of this. But hopefully I can go through some of the things that you do and do not do in situations of seizures. And maybe we learn a little bit about what you can do and what you do not have to fear with epilepsy. All right, so definitions. Okay, what is a seizure? A seizure is effectively a short circuit or an electrical storm in the brain. Now, our brain is effectively an electrical appliance. It's made up of trillions and trillions of brain cells. Every time we have a thought, It's our brain sending electrical signals within itself. Every time we raise our arm, for example, our brain sends an electrical signal to the arm. Every time we feel something on our arm sends an electrical signal to the brain. And as with any electrical appliance, it stands to reason that a short circuit can occur. And when a short circuit occurs, a seizure happens. Now, depending on where in the brain the seizure, the electrical storm happens or the short circuit happens, seizures can take on different manifestations. And this is why there are so many different types of seizures, and seizures are experienced differently in everyone. So if a seizure can occur in a very specific part of the brain, this is what doctors call a focal seizure, where it leads to very limited symptoms such as the jerking of a single arm. It can even lead to certain manifestations like emotional responses or abnormal sensations. Or it can occur in the entire brain. And this is what is commonly depicted in movies and TV shows where somebody loses consciousness and has severe jerking episodes. So the episode itself, an event of a seizure, is called a seizure. A tendency to suffer from seizures is called epilepsy. So if you've been diagnosed with a condition of epilepsy, it means that you are slightly or to a certain degree more vulnerable to suffer from seizures than what we would consider the average normal. Okay, so MCQ time. Who can have seizures? People who have had strokes before, people who have had traumatic brain injuries, people with congenital brain diseases, or sort of regular folk like most of us here who may or may not have had any conditions or diseases before, or all of the above. You can take a gander about what the answer is based on what I've said before. And really the answer is all of the above. In simple terms, anyone can have a seizure. I can have a seizure, or my colleagues sitting around me can have a seizure. It's just a matter of how much stress our brains are put under. And under certain conditions of extreme trauma or extreme physiological derangement, this is a medical term, anybody can suffer from a seizure. Anybody's brain, which is again an electrical appliance, can be tipped into a situation of suffering from a short circuit. Okay, so in simple terms, how do seizures occur? Everybody's brain has a certain resistance to seizures. Okay, that's what we call the threshold. That is the limit to which our brains can suffer aggravation before it goes into a situation of a short circuit. And then on the other hand, you've got triggers, or what we call precipitants. These are the sources of stress. Now, when the triggers exceed your threshold, in other words, your stress exceeds the ability of the brain to resist going into a situation of a short circuit, then you have a seizure. It's as simple as that. So this is a bit of the basic science that underlies how seizures occur, some of the mechanics by which seizures occur. And with this concept, we can understand everything that we do as doctors and sort of the perspectives that we use to think about how to handle the occurrence and the prevention of seizures. Okay, so what can lower your threshold? What can make your brain a little bit less resistant to going into a situation of a short circuit? Now, again, I go back to the analogy of an electrical appliance. If you've had a TV or a computer, any kind of damage to its electrical circuitry, any kind of abnormality to its perfect architecture can render it more likely to go into a short circuit. And the same principle occurs with the brain. So if you've had a previous injury to your brain through any kind of mechanism, for example, an infection, for example, a scar, for example, a stroke, all of these areas become very vulnerable to spark off an electrical storm. And this makes your brain more vulnerable to suffering from seizures. Now, it's important to note that in many patients, often there is no clearly identifiable cause. Now, this may be because the abnormalities in the architecture are so fine that current medical technology, the best scans that we have, the best MRI machines that we have, the most detailed electroencephalograms, which is the electrical monitoring devices that we put on your head, cannot find where the abnormal circuitry is. And this is actually an exceedingly common thing. Nevertheless, as I'll talk about in a little bit more detail later on, it's something that we do need to look for hard so that we can do our best, in whichever way is possible, to restore the threshold. So once again, having epilepsy means having tendency to suffer from seizures, means having a greater vulnerability than what we would consider the normal average to suffer from seizures and to be tipped into a state of short circuit. Okay, so I keep talking about stress. I keep talking about precipitants. So what constitutes these elements that can be considered stressful for the brain, that can make it a little bit more vulnerable to, a little bit more likely to tip off into an electrical storm? So really, this is anything that disturbs what is a perfect normal state of equilibrium in the body. So this can range from anything to exceptionally high or low blood sugar levels. This can range from anything from this can include anything like exceptionally high or low levels of salt, potassium, or magnesium. Anything that your body would need to maintain at a constant, comfortable level. There are some other things that we encounter in our everyday lives that will also contribute to a tendency to trigger off electrical storms. So lack of sleep is a very common precipitant of seizures, especially in patients who already have epilepsy. Now, this is not something I recommend anybody try out at home, but if you don't sleep for 7 days, there's a good chance that even somebody who's never been diagnosed with epilepsy before might suffer from a seizure. So a lack of sleep is a very powerful trigger for seizures. Psychological stress can often put us into a state where it's more likely for a short circuit to happen. And then, of course, the list goes on and on and on. Infections in the brain. Infections in the brain or infections anywhere else in the body, for example, your lungs with a pneumonia or your urinary tract with a urinary tract infection. All of these things make the brain a little bit more flammable electrically. So this is how we think. And again, I come back down to the basic science. The key concept here is we are trying to make your brain less likely to be tipped off into a state of electrical storm. In other words, we want to raise the threshold. This is no different from designing your home such that it's less likely to catch fire, to put flammable materials in controllable environments. And when somebody suffers from seizure or suffers from epilepsy, we want to make sure that they have as few triggers or as few precipitants as possible, such that it is less likely for them to be tipped over the edge. So if somebody comes to us having had a seizure or having something that is suspicious for a seizure, the first thing we want to do is make sure that their blood sugar is fine, their salt levels are okay, they're not having an ongoing infection, and that they are as close as possible to what we would consider a normal, comfortable, healthy state. And then we go hunting for any reason for why their thresholds might be lowered, why a brain might not have normal circuitry, why a brain might be a little bit more vulnerable to going into a state of a short circuit than what we would consider a normal average. And then, of course, once we've identified these factors, we treat them. We eliminate triggers. If you have an infection, we treat the infection. If your blood sugar is too high, we lower the blood sugar. If the blood sugar is too low, we raise the blood sugar. If you've had not enough sleep, we give you a big smile, a wave, and say, please try to sleep more. And then we write a memo to your employer and say, please let this employee sleep more. Okay, then after that, we try to raise your threshold. So now oftentimes thresholds are, so there are a number of factors that might lower your threshold that we will consider unmodifiable. So for example, if you have a scar, there's no way for us to repair the scar. But what we can do is attempt certain techniques, such as with the use of medications, special diets, and in extreme cases, surgery, to remove this or to reduce the likelihood that this abnormal area of the brain can cause a spark, and that then triggers an electrical storm, which then evolves into a full-blown seizure. So this is really how we think. Most of the questions that a doctor asks you, or most of the techniques that a doctor uses when they examine you in the clinic, is targeted towards this purpose. Okay, so this is a very important concept here. Are seizures dangerous? And actually, for the most part, they are not. They look very dramatic, and as they are depicted in popular culture, they can be, a source of a lot of fear and a lot of panic. But actually, and this is, and again, I remind all of us, this is a very important concept to think about. A seizure is, for the most part, and in most cases, not dangerous. What is dangerous, however, is falling down and smacking your head. That's the dangerous part. Okay, the dangerous part is losing consciousness at the wheel of a car and crashing into a tree. That's dangerous. Okay, but the event itself, for the most part, is not dangerous unless it doesn't stop. So seizures, if it goes on for more than, the medical threshold we consider is about 5 minutes, there is a potential for a seizure to cause permanent damage to your brain. But anything below that, and most seizures do stop themselves after a few seconds or short minutes, wouldn't be considered dangerous. Now, with that knowledge in mind, right, what do we do in the event of a seizure? Now, of course, there's a very strong temptation whenever we see somebody convulsing or jerking or undergoing something that looks very distressing to them to try to do something. Actually, the most constructive thing we can do is allow the seizure to pass. And if the seizure doesn't pass and it goes into the sort of length of time where it might potentially be dangerous, then to activate the emergency services. What we absolutely should not do is attempt to struggle with the patient or manipulate the patient physically. Now, there's a common sort of there's a common concept within the community that perhaps, when somebody's having a seizure, we should try to put a spoon in the mouth to stop them from biting their tongue. That is strictly not recommended because the spoon is an even greater danger to the patient than simply waiting and allowing the seizure to pass. Now, it is true that oftentimes a seizure can lead to uncontrolled contractions of certain muscles, which is why we get convulsions, and the patient can in fact bite their tongue. But we do have to appreciate that there's nothing we can do about that out in the community, and the best thing that we can hope for is for the seizure to pass. And if the seizure doesn't pass, then emergency services can terminate the seizure, and that's how we stop the patient from biting their tongue. Again, I repeat this, do not try to struggle with the patient, do not try to put anything into the patient's mouth. Okay, so now we go into some of the more practical aspects of living with epilepsy. Okay, by and large, patients with epilepsy are encouraged to live a life with as normal a routine and as normal employment as patients without epilepsy. And in fact, out in the community, if you look around, most of the time, you may encounter patients with epilepsy who walk past you on the street, stand next to you in the MRT, and you would never know that they are patients with epilepsy unless they have a seizure in front of you. So again, we encourage our patients to live as normal a life as possible with as normal a routine. And we have a lot of services to help you come to terms with the fact that, sometimes an unpredictable event might occur. There's some specific exceptions, of course, and sort of these exceptions lend themselves to common sense insofar as you necessarily need to avoid any activity that would be life-threatening or dangerous if they should occur all of a sudden and cause you to lose consciousness all of a sudden. And these include things like heights, swimming, and I've highlighted driving there because it's relevant to a lot of people's livelihood. Unfortunately, legislations and regulations do prevent us from necessitate that people with epilepsy do not drive, and this is for their own safety as well as the safety of the community. Okay, so these are some of the questions that as doctors we encounter in the clinic quite often. So how does doctor decide how much medicine to give? Again, I go back to the primary concept of the thresholds and the precipitants, and the objective of the medicine here is to raise the threshold, to give your brain a little bit of resistance to fire, resistance to electrical fire, and the process of that is by slow escalation. So at the start, we think about what are the appropriate dose of which medicine based on your individual profile to give, and then we go up and down based on your response to that. So it is a bit of a try and error process, and sometimes it may take sort of a few visits and a few seizures and sort of a few weeks to months to come to the ideal dose for you, which is a good balance of side effects and benefit. So can you be cured from epilepsy? So this is a slightly difficult question to answer. And again, I remind everyone that epilepsy means tendency to suffer from seizures. There are certain situations, particularly in patients who have had epilepsy when they were young and sort of have grown to live and be comfortable with it into their adulthood, where the occurrence of seizures and the tendency to suffer from seizures decreases. But again, this is a very individual thing. It's important to note that scars, as I mentioned earlier, cannot be repaired, but there are many situations when good control is achieved for a patient's epilepsy using medications, using certain techniques, and then the patient can live their lives as normally as possible. Okay, the last one, can medicines affect my intelligence? This is again another question that we encounter quite commonly in the clinic, and the short answer to that is we don't really know, but for the most part, we consider it more productive to treat an epilepsy than to leave an epilepsy untreated. And whatever dulling effects seizure medicines might have, they are far outweighed by the benefit of reducing the number of seizures, which in and of itself can reduce your function. Now, to answer this question with genuine nuance, we need to understand how doctors think and how we know what we know and what we accept as fact. And to do that, doctors depend on what we call evidence, which is observation of hundreds or thousands of people who have gone before in exactly similar situation, and then we make a determination: is this single isolated effect something that is observable. And the problem with measuring intelligence is that there's so many different factors. Everybody's in a different situation that it's impossible to tell. By and large, I do encourage everyone not to be fearful of the medicine that is prescribed, and to have sort of an informed conversation with your doctor about some of your fears that you might have. And I think for the most part, you will probably come away reassured of that conversation. And oftentimes, if a medicine is recommended, we do consider it likely to be more productive in all respects, including cognitive function, to treat a seizure, to treat a condition of epilepsy rather than to not treat it. Okay, I do apologize for the slightly more complex slant of the last few slides, but if there's any clarifications that everybody wants to make, this is an opportunity for us to do so.
Thank you so much, Dr. Kong, for such an insightful sharing. There seems to be an emerging interest among our participants online, and I think they have posted some few questions. Perhaps some of it can actually be we can actually combine into one full question for you to actually address. So I think coming from Miss Alice, she actually asked, why is there childhood epilepsy? Was a root cause for it? And perhaps we can also see whether there is actually a connection if there were possibilities of poor fertility health from the mother causing the child to have seizures. Yes, would you be able to take this on, Dr. Kong?
Okay. So I'll address the question from Alice first. Okay, so again, I come back down to the concepts of precipitants and thresholds. And again, the definition of epilepsy is a lower threshold. That means your brain has some kind of microscopic or macroscopic, macroscopic means visible, abnormality that renders the fine circuitry inside more likely to cause an electrical storm or a short circuit. Okay. Why does this happen in children? Well, there's a million and one reasons, and so if you were to consult a textbook, the list is infinitely long. But the basic principle is anything that causes the brain to not have an architecturally perfect structure can result in a tendency for short circuits to happen. And this can be because of infections while the child is in the womb. This can be because of developmental issues where certain parts of the brain don't go well enough. This is a condition, some of these conditions we doctors call focal cortical dysplasia. Focal meaning in a specific area, cortical means the cortex of the brain, which is the meat of the brain, and dysplasia means abnormality. So these are some of the examples of things which may affect a child's perfect brain architecture, which can then result in the child developing epilepsy in the future. Now, again, I repeat, this is very, very long, and there's no way, and there are very oftentimes there are few ways to predict when this might happen. And of course, there are a lot of situations where epilepsy only reveals itself further on in a child's life. So there isn't a simple answer to this question. And how much control we have over it, again, it's hard to say. Like, it really depends on which specific condition we are dealing with.
Yeah, certainly, definitely not an easy question to tackle. And we are getting more questions coming in from our participants as well. So perhaps some of the questions we may be able to actually post it directly online to actually address these. But one of the other questions that our attendees actually would like to know is, I think there was a question about the how does the Keppra, is there any long-term side effects for taking this medication? Yes, coming from Mr. Alvin.
Okay. All right. So, well, that's actually a very common question. Okay, so Keppra is levetiracetam. Is one of the newer seizure medicines. The history of seizure medicines includes many different types of medicines that have been used for decades, and Keppra is one of the newer ones. And by and large, newer always tends to suggest better, okay, for one of a more precise way of expressing this concept. Now, Keppra is attractive to be used because of a number of reasons. Like, it doesn't affect the liver, for example, which a lot of older anti-seizure medicines do. And Keppra is actually quite easy to dose, and its levels in your body are quite stable. So all of these are positive things that surround Keppra. We have observed, however, that in some patients, Keppra can sort perhaps, and this is a possibility, a theoretical possibility, can perhaps worsen mood disorders such as depression, can make a patient feel a little bit emotionally worse than they would otherwise. In certain extreme situations, in patients who already have very vulnerable brains, there is a possibility that Keppra can lead to slightly increased levels of drowsiness. And then, of course, there are precautions with Keppra with regards to its use in patients with kidney failure, because Keppra is cleared from the body with the kidneys, by the kidneys. So if you take a box of Keppra and you pull out the information sheet and you sort of unfurl it, there's going to be tens and tens or perhaps hundreds of things listed down. It is important to remember that this entire list is designed to be as conservative as possible, which means that any kind of side effect, possible or confirmed, that anybody has experienced would be included in this list. So as a recipient of a medicine, not just Keppra, anything, including something as simple as Panadol, it is important to bear this in mind, that when you take a medicine, and when a medicine is suggested to you by a doctor, the objective here is always to offer you more benefit than the potential side effects. And it is unavoidable that anything that we do may have a theoretical risk of certain side effects. But by and large, we do need to keep in mind and keep an eye on what it can do for us. And in Kepra's case, it is a very effective drug at raising the threshold and giving you protection from seizures itself, rendering quite a number of dangers that we want to avoid.
Thank you so much. I think we only have time for 2 more questions. So one of the other interesting questions that we got from our participant would be about the dietary wise. Are there any types of special diets that patients with epilepsy they find it effective for?
Okay. So I did mention this earlier on in the slides, and I do apologize that I didn't expound on it because of time constraints. Okay, but when we talk about special diets, we are referring to diets that are planned for and administered by professionals, doctors and dietitians, that actually have very, very strict criteria. Okay, if you would like to sort of look it up on your own, it's what we refer to as a ketogenic diet. Okay, now this is very different from what the word keto diet suggests in sort of the general community. Okay, this is not something that is easy to administer individually and personally by simply looking at certain internet sources. So yes, there are certain diets that can be very helpful in reducing seizures. We usually apply this in sort of fairly extreme cases, but I do need to qualify that they do not include a lot of the fad diets that we encounter, such as what we commonly like to call keto diets or carbohydrate diets or protein diets. These do need to be administered by professionals, and they do need to be administered sort of in a very controlled setting.
Definitely a very good way for us to actually disbound all these advices from the internet. Yeah. So okay, the last questions that we'll be taking on would be from Mr. Lee, Miss Lee or Mr. Lee. Does age play a part in tendency of developing epilepsy for no apparent causes? In example, older folks.
Okay. Well, life is very complicated. There's 1,000,001 things that are constantly in play with regards to our existence. There are 1,000,001 things that can happen to us as we get older, such as strokes, such as the development of dementia. So again, I want to go back to the basic science here. Okay, epilepsy means a brain that is not architecturally perfect, a brain that has certain damage in certain areas, whether or not it is microscopic or slightly larger than that renders it more vulnerable to developing short circuits. And there are certain elements with age that can result in a situation where your brain becomes more damaged than it was when you were perfectly young and healthy, such as, for example, if you get into a car accident when you're 75 years old, such as if you have a stroke when you're 67 years old. Now, those are individual identifiable factors. Okay, but at the same time, there are a lot of types of epilepsy that are caused by conditions that occur when you are younger. And we do know that there are a lot of patients who have no apparent cause, who do have the epilepsy or seizures that develop as a matter of, no specific reason when they are younger as well. So again, with this question, it's a bit hard to answer specifically, but I think it's important to sort of go back to the first principles here. If you sort of have a perfectly healthy life, you never get into a car accident, you never bang your head on anything, you never get a stroke, you follow our Prime Minister's advice and drink coffee with no sugar, then and you never have a stroke as a result of that, then you might go through the entire duration of your life never having the vulnerability to more seizures. Okay, but the number of diseases, the list of diseases is basically infinite. There's thousands and thousands of them, and if you do get any of them, which of course increases the chances of which increases with age, then you might suffer from epilepsy as a result of that.
Thank you so much, Dr. Kong, for taking on these questions. We will try our best to reply in the chat, in the Q&A section, but we'll have to move on to our next speaker. All right. Okay. Thank you so much, Dr. Kong.
Thanks, everyone.
Okay. So for next, I would like to actually welcome our speaker, Ms. Evelyn Silva, a senior principal psychologist at the National Neuroscience Institute. Ms. Evelyn's work involves working with persons living with neurological disease and their care partners. In addition to neuropsychological assessment, she also provides cognitive stimulation and counseling. She is very much involved with care partners in engaging persons living with dementia. She has been pivotal in the development and delivery of group works with persons living with dementia. And today, we are privileged to have her share with us on the topic, Stay Calm and Carry On. Ms. Evelyn, please.
Am I online? Oh, hello, everyone. Good morning, and thank you for being here. So let's all stay calm and carry on, especially me. Okay. All right. So let's see. So these are the key points I'll be going through with you, and so we'll get on to it. So as you heard from Dr. Kong, the epilepsy, it's a very complex condition, and it also affects the mood, and it's bidirectional. That means mood can also trigger off some seizures. All right. So are we good? Yes. Okay. So mood will trigger off some seizures, and studies have shown that being overly anxious of the seizure experience can trigger off an epileptic attack. So it's like I said, so it's bidirectional and it's so complex, and of course it affects the quality of life, especially for those who are living with epilepsy. So I'd like to talk to you about mood disturbance. In general, when we talk about mood disturbance in epilepsy, we are talking about the twins. The twins, what I refer to are depression and anxiety. Okay, so what is depression? Depression is prolonged. So I'm got too many computers, so I need to be calm. Okay, so depression is a prolonged feeling of helplessness, hopelessness, sadness, whereas anxiety is a condition where you're overly feeling uneasy, pacing, walking up and down. So we get that in mind. Okay, all right. And so these are some of the factors, as you have heard from Dr. Kong, that affects the mood. You can see brain chemistry, hormones, side effects of medication. And I would like actually to, before you get all too concerned about what side effects of medication, yeah. So as we go on the different stage of development, our life, some of us have other comorbidities, other general medical conditions that can affect the medication. So hence, please talk to your physician about it. So these are the factors that may cause the mood disturbance. And these are the triggers that can cause the seizures, which you have heard Dr. Kong saying. And underlying all of this is, you can see, the non-compliance to medication. So hence, you can see that looking at the factors that cause the mood disturbance and the triggers for the seizures, you can see there are a lot of overlaps. So again, it comes to the point where one affects the other. Okay. Yeah. So this is the impact of for those who are living with epilepsy. I'm sure you are living with it, so you will know what is this all about. The depression and anxiety on persons living with dementia, your suboptimal functioning, you can't function as well as your peers. It affects your job, it affects your schooling, it affects your interpersonal relationship for people who don't understand or people who don't have the patience, and also affects your symptoms of recovery and your quality of life. Okay, quality of life is the buzzword, QOL. We all want a good quality of life. So, so what to look for? What to look for when to identify what is this depression, anxiety? So we put in the three broad categories, which is here. Cognition is the thinking, what you're thinking. Emotion is what you're feeling, and behavior is what you're doing. All right. And so, how do we identify what's the cognition? What do you mean by cognition? Cognition is when we have poor concentration, we are easily distracted, and we make difficult we make difficult decisions. We have difficulty making decisions, and we have this automatic thoughts, all the negative thinking. What ifs? I do this? What if this is happening? What will happen? And again, remember what I said. Sometimes overly anxious will trigger off a seizure experience. Okay. So then the other one is emotions. Worrying is all of us worry. We are humans. All of us worry. We all go through all this low mood, feeling overwhelmed by things. So these are the emotions, but at what level? Okay. Behavior, feeling less interested, loss of interest, lack of energy, avoiding social activities because of what we think we are going to experience or likely to happen. And then some people, to overcome all this, to forget everything, they drink. Okay. And then you get irritable and short-tempered, and we get aggressive because we are very confused of what is happening, what is our life going to be like. So all this affect our mood, right? And so how do we know if we need treatment? We know we need treatment when we feel all of this. It lasts a long time, and it's severe that it interferes with your relationship, with your family, your friends, your colleagues, and also impacts on your job. All right. So when you get into this kind of situation, we do recommend that you talk to your clinician, and if clinician, and be open to a referral to a mental health professional. So mental health starts with MENTAL. So mental is me. So you first, all right? So how do we manage this? So while you wait to see the doctor, let's see whether there are some things you can do so that it won't start that spark that leads to that storm, the electric storm, which Dr. Kong was talking to us about. So is the situation within our control, or is the situation beyond our control? So this is a little diagram that we can look at to help us. If the situation is within your control and you act on it, like taking your medications or managing the stress, then the situation is manageable. You can live on as well as you can. If the situation within your control and you says, oh no, oh poor me, oh my, and you sit on the pity pot, and some well-meaning relatives will say, yeah, you sit down, you don't move, because if they are within sight and you're sitting down, you're less likely to get in trouble. That's what we call learned helplessness, and you're not going to get moving from that little chair and the little pity pot that you're sitting on. But if the situation is beyond control and you try and you get distressed because you're not getting the help that you want, and the help might be not within your ability level, but you need help from someone else. Okay. And if the situation is beyond your control and you accept it, this is something different. It's beyond control. So some people have a diagnosis of a medical condition, but they don't accept it. They deny it. No, I'm okay. And then they say, I don't need this medicine. And it normally happens with people who got hypertension, cholesterol, diabetes. They say, no, I'm okay. What? No effects. Then you're going to get into trouble. So if the situation is beyond your control and you don't act on it, accept the diagnosis and do something about it from advice from your doctors. Okay, that's an acceptance of your condition, and we can see what we can move on with that. All right. So let's look at some strategies here. Some strategies here that we can do to see whether the situation is within your control and what you can act on. So to how we can go into the orange square here to see that you can manage it. All right, some strategies and some treatments to keep the sparks in control. Okay, so first and foremost, ask. It's okay to ask. Don't be afraid to ask. Ask all the questions that you can't ask. any things, any doubts? Is this symptom normal? Is this going to happen? What's the frequency? What can I do? Like what the questions you asked earlier to Dr. Kong. Is this diet okay? Is the brain okay? Is this medication okay? So ask. And something that happens in our clinic, which we see, the patients and the family members come and see the doctor. The doctor asks, "You have any questions?" No. But the moment they step out of the clinic, oh dear, I should have asked. So we do recommend you have a little notebook, write everything down as and when you feel, and the comfort of your home. And then when you come to the clinic, show your doctor. So it helps. It reduces the stress for yourself. Okay. So ask whatever you need to ask. There's no stupid questions. There may be stupid answers, but no stupid questions. All right. So now let's work on the mood. The mood. Just now we talked about the cognition, the emotions, the behavior. Learn to relax. Stay calm. Okay. Label the feelings that you have. Are you feeling stressed? Are you feeling anxious? Are you feeling afraid? Are you feeling glad? Okay. Sad, mad. Okay. And be curious. If there is something happening, if the person I'm sitting in the clinic, who's also seeing the same doctor, and how's the person so good and I'm not so great? Ask the doctor. There might be some answers he can give you. Okay. And remember that all emotions, no matter you're mad, you're sad, you're glad, your craziness, will pass. Okay. It will pass. It's all cyclical. We're all human beings. We interact with our environment. We interact with people. Okay. And this is another thing on working on mood that has been tried and tested and works and impact. You might be doing it, but you are not aware of it. Be mindful of yourself. Be mindful. Be aware. Be aware. Do a body scan. Be aware of your environment. Be aware of your breathing. Okay. And then and letting go of the negative emotions. Remember, I said earlier, all these automatic thoughts. Oh, what ifs, what ifs, what ifs. Be aware of the negative emotions and see what you can do about it. Okay, watch it and refocus your attention. If you find that you're having too much of negative thoughts, distract yourself. So we are very good at distracting, right? We got a lot of Netflix. We got a lot of things that we can do. Listen to music. Watch a comedy. Okay, don't watch too much of the soapy Korean dramas. Okay, it really brings you down. At least it brings me down. No matter how good looking they are. All right. So now take control of your seizures. Learn to identify the seizure triggers. What was it? Okay. Just now we went through. Dr. Kong also went through. Learn to identify what is it uniquely about the seizure, the triggers that created the seizure. So this is when it's good to have a workbook. What happened before? Could you have been having a party, a good time? Or could you have been watching some flash photography? Could you have been watching not taking a medication? Okay. All right. So, and learn to do this relaxation techniques, things about staying calm, breathing. Some people believe in yoga. Some people believe in just sitting down there, chilling out, okay? Listening to music, like I said, or doing some art, okay? So learn to relax. Have a thought record so that you can measure whether you're having too many negative thoughts, automatic thoughts, okay? So this is a workbook. So remember what I said, so situation within your control and situation without beyond your control. So that what are the triggers that can help this is on reflection, not when you're having it. It's on reflection. What were the triggers? What were the antecedents? What were the precipitating factors that happened? And then you write, why? Why do I want to take control? I want to take control because then you fill your answers. Okay, that I'm having a wedding that is coming, my friend's wedding. I'm going to meet all my old classmates. Or I want to go to Taylor Swift concert. Is it okay for me? So if the lesser the triggers I have, the lesser the seizures I have, can I be having a good time? Yes, you can. All right. And so you also look at what are the obstacles. How do I need to prepare for that? Okay. All right. So let's go on. Triggers. Okay. So remember I said about triggers, and on your reflection of this worksheet, triggers. So look at all the triggers possible. I just written a list down here, but you have to look at your own unique self. Is your refrigerator, is your electrical equipment working? Is it been serviced? Is there anything faulty? I mean, it's in your own body, huh? And then you see something I can do about it. Can I change it? Can I avoid it? And so looking at the triggers, you can have an idea of what I'm talking about to your own unique situation. Can I accept it? So I have this condition. So what can I do about it? And if even if it's the stress or hormones or what, especially with women, as we go through all our development stages and our menstrual cycles, it also affects us, can be triggers for some. So having all this, build your resistance. Okay, your own unique situation, and change your perception. You change the way you think, you change the way you feel. And when you change the way you feel, you will change the way you behave, the way you do your things. So this is a grief cycle. A lot of us have gone through some losses in our lifetime. Okay, if you are sitting here as a human being, you would have gone through some losses. Maybe you lost getting to the school of your choice, or you lost getting the bid for your COE for your car, or you lost getting that $5 million prize that a lot of us missed a couple of weeks ago. Okay, so this the grief cycle, and having a medical condition where it impacts your life and your love for lots of things, love for life. You had gone through all this grief cycle. There's been some loss, some anger, some denial. No, it's not. I don't have this condition, so I don't need to take the medicine. But having that loss, you in your own lifetime, in your own life experiences, you have recovered. You have recovered from some small losses, some more impactful, that have formed your belief system, your value system. So you have gone through this experience, and so we would like you to keep that in mind. Keep that in mind and accept the process and know that you can recover. So I'm going to leave you with this shield to fight and manage all that stress. So based on your life experience that have strengthened you, your internal resources, your support network, people who you know, people who love, who care for you, and your attitudes and your beliefs, your religion, whatever you feel you are aligned to, and of course your physical care to make sure that fridge is working, reduce bug. And you come up with some action skills. What can you do to manage the situation within your control? So now I'd like to talk to you, especially I'd like to bring attention of parents who have teens with epilepsy, okay? Some pointers for you. As your teen is growing, as they were children, everything you say, they listen to you. So these are some pointers you need to do. Teens are at the stage where they're going to develop. Just like any other teens with epilepsy also wants their independence. They're going to develop into adults. And we would like them to be as independent as possible, because we are really a bit tight sometimes. I'm talking as a parent, okay? Right. So you stress consistency, because if they don't take their medication on time, it's always a risk for a seizure, all right? So stress on consistency, make sure that they are having their medication. Okay, young children are more compliant, but teens are a bit more ambivalent. I can do it, all right? And then discuss special college concerns when they're going away. As children do go away, whether they are going to live on their own, they go to college or go to hostels, okay? One of the things that we're very concerned is sometimes they are exposed to certain things which we have protected them from. And then also because of college studies, we want them, talk to them, have an open discussion, don't shy away of impact of this sleep deprivation and substance use. Sometimes they are very concerned, curious, they want to try. And this too are very serious seizure risk. And in addition to that, they are well-meaning, they want to do well, and they avoid all-night cramming for exams, okay? And teens also, take care of your own health. You are their role model. And they learn good health habits from home. So if you are taking your vitamins, you are taking your medication, it shows to them the importance of it. And advocate for your teen. Ask them, ask them, are they okay? Is there anything happening? Not in interrogative, like all teens, they don't want too much of interrogation, but discuss with them, be their advocate, speak for them, and then expect more. Encourage them to lead. Parents are often nervous when children spread their wings. I'm being a parent, yes, I was terribly nervous. but encourage them while recognizing and managing their risk. Encourage them to lead his normal, active life, but be aware of what are the risks and make sure they have all the safety nets. Okay, this was especially to teens. So now moving on, with sake of all that I said, I would like to remind you to remember this acronym MBS. No, sorry, BAMS. Body, mind, and soul. So take care of your body. These are three categories that you can remember. Body, nutrition. Make sure you eat, because if you don't eat, there's something's going to happen. It works for everyone. It's not only for persons living with epilepsy. Make sure you have sleep and do exercise. Exercise, again, I would always ask everything with caution. Talk to the doctor. Talk to your primary physician. Meditation. The mind is to help you in the relaxation. Some people do well with yoga. Some people don't. So if you don't want to do yoga, there are a lot of variations: deep breathing, meditation, mindfulness, body scan. Look at what is happening to me from my head to my toe. All right, and all the way to my fingers. Is there any tingling? How do I relax all the tense muscles? And soul, the spirit, the music, the leisure, and the relationship. Because everything, relationship, we are not an island. We are social beings. We need relationships. Be inclusive in a lot of things. But underlying all this is your compliance to medication. We cannot forget that, okay? We cannot forget that. That means we are not in denial. We're accepting our diagnosis and we're moving on. So, as Singaporeans, I would like to leave you with a visual treat. Diet. The question has been asked earlier. So this is a sample of, this is some options you can think about. But I do caution, please talk to your primary physician. And research have shown some studies done, and this is a sample of a diet for persons with epilepsy. Again, you can see there is the 4:1 fats to carbs and protein. But this is just a sample to show you that it is possible. But please, again, talk to your physician. So if you don't want to eat pork, you have an option to go Brazilian, eat chicken breast. And if you don't want chicken, you don't want to go Brazilian, you can have Indian. And of course, that's a Switzerland, I think it's vegetarian, huh? Okay, these are just samples. Please talk to your physician, who will arrange to see whether you can do it a dietitian. All right. Okay, these are some of our reference, and this we'd like to acknowledge our nurse clinician, Peshwan, and the epilepsy team, and my co-host who's doing the Mandarin session, Lavinia Lim, and our NNI comms people, and all of you for your kind attention and taking charge of your health. Thank you.
Thank you so much, Ms. Evelyn, for the invaluable information. Do stay online because we might want to take some questions from our participants as they come in. But I love the fact that you actually shared about the grief cycle in epilepsy. And we took note that these stages in the different grief cycles actually may not come in order, and it may even overlap with one another as well. And you did mention about the importance of mental wellness that one needs to undertake in order to get themselves in motion and also in control of their own well-being overall. But at which point in these cycle stages, at any of the cycle stages, will it warrant them to actually seek professional consultation? If let's say they are unable to manage themselves at any point of that stage.
Okay, so as I mentioned earlier, as long as it affects your functioning, but even if you affects your sleep, you can't sleep, you're doing an all-nighter, you cannot sleep, you go to bed but you can't sleep, call your nurse clinician and tell her about what is happening. And so, like I said, so what we will do is to see whether there's any indication of your medications that is affecting you, because like I said, as we live on in life, and then Singapore is the aging population is getting older, we have also, the longer you live, the more there are other conditions that come on to you, like I said, hypertension, cholesterol, and see whether that medication is happening. So your clinician will be the person who will be able to tell whether it is psychological or it is a pharmacological issue. And having said that, with NNI, sorry, I'm talking for NNI because I know NNI better. Our clinicians, normally including Dr. Kong, would refer you to our counselor and our psychologist. So we'll be together. We'll do the medication, pharmacological, and the non-pharmacological. So anytime you feel that you're not doing so great, do talk to a nurse clinician and see what she can do to help you to arrange a session with us. And if you feel you're getting more irritable, so we're talking about frequency and the severity of your situation. And like I said, come in as soon as you feel you are not coping well. And so we can come in and help you there at that level before things get into an electrical storm. Like I said, you don't sleep, it affects your condition. Your mood disturbance will affect your medical condition. So let's nip it in the bud.
Thank you so much for taking that questions. So we do have some questions from our participants asking on the programs, the support programs for our epilepsy care patients. So I think we've answered in one of the panelists have already answered. So you can check out some of the resources that we actually take note of. The Singapore Epilepsy Foundation. They actually have periodical meetings for our patients living with epilepsy. So take a note for the information in one of our answered questions over there. All right. Okay, thank you so much, Ms. Evelyn, for taking on the questions and also sharing all this invaluable information as well. So we'll be taking actually a short 5 minutes break. Please do remain in the webinar and we'll be back shortly. All right. Thank you, everyone. Yes. Okay, so we're going to have some participants joining us from the Mandarin session. But welcome back, everybody. Okay, so today we are honored to actually have invited two guest speakers from MINDS, the Movement for the Intellectually Disabled of Singapore. Let us introduce both Dr. Bhavani Sriram and also Mr. Manikandan Palinival. Dr. Bhavani is a doctor with MINDS, and she has been helping to diagnose patients with suspected intellectual disability and autism spectrum disorder. She is also currently working with MINDS to develop a national healthcare framework to help patients with intellectual and other developmental disorders. Together with Dr. Bhavani, we have Mr. Mani, who is also a senior occupational therapist with MINDS. He has been a senior occupational therapist working with MINDS since 2005. That's many years, has worked with many different centers across the MINDS organization, including employment development, training, and job placement support program for persons with intellectual disabilities. Prior to MINDS, he has been working as a clinical occupational therapist in Indo-American Hospital Brain and Spine Center and a neurospecialty hospital in India. Over his many 20 years of experience, he runs many workshops and seminars for parents, caregivers of persons with intellectual disabilities, their volunteers, and staff. He is also an active clinical educator for students in the field of occupational therapy. His interest lies in the areas of epilepsy and dementia for persons with intellectual disabilities. They will be both speaking on caring beyond conditions, supporting people with intellectual disabilities and epilepsy. So Dr. Bhavani, Mr. Manikandan, please.
A very good morning to all of you. And thank you very much for joining in on a Saturday morning. And thank you very much for the organizers for letting us participate in this public seminar. I'm actually a physician who is looking after persons with intellectual disabilities. And my role today is going to try and talk to you a little bit about health-related issues in persons with intellectual disabilities and epilepsy, and also talk a little bit about the psychosocial aspects. So just for you to understand a little bit about MINDS, is basically an organization, it's a social service agency, and we are particularly focused on the advances for the development of persons with intellectual disabilities. And this is mainly done by providing person-centric services. You should also understand that we actually work as a lifespan basis. So we start looking after young children all the way from special education schools into adult disability services. We focus on community services, and you can see a wide range of services that is mentioned here, of which one of them is the MINDS clinic. But we also provide residential services and respite care. So moving on to the clinic, and what exactly do we do, and how can we focus on persons with intellectual disabilities and epilepsy, and are they different? Is there anything that is different that we need to focus on? The clinic basically was set up as early as 2017, and the focus is basically to bridge the prevailing social medical gaps. We would like to have an ID-friendly public health system, and we don't want them to be isolated. Therefore, we are hoping to form partnerships with the community in order for people to understand the needs of persons with intellectual disabilities better. So I'm just now going to focus a little bit on epilepsy, and this is an elegant survey that is done looking at the quality of life of persons with intellectual disabilities with epilepsy and comparing them to neurotypical people with epilepsy. And it's clearly noted in the study that there is a significantly lower quality of life in persons with intellectual disability with coexistent epilepsy. And why is that so? I'm just going to focus on 4 important factors: seizure burden, anti-seizure medications, and side effects. And these were actually caregivers who actually in the survey mentioned that these were the 4 important factors that affected them most. And why is it so? It is so because we understand that the prevalence of epilepsy in persons with intellectual disability can vary anywhere between 22 to 30%. In those with milder forms of intellectual disability, it's about 10%. But in those with moderate and severe, the coexistent morbidity is nearly 30%. And it's also understood that the prevalence of epilepsy is nearly 20 times higher in persons with intellectual disability than those from the general population. So you can see the burden is obviously much higher. But it also goes to show you that how do we recognize epilepsy in persons with intellectual disabilities? Because for those of you who look after persons with intellectual disabilities, you clearly understand that many of them do not have the communication skills. So it is the lens of the caregivers who have to identify that there's something wrong and could this be epilepsy? And if you don't have enough educational background to understand that there's coexistent epilepsy and intellectual disability, you may not even be able to diagnose this condition. So I'm just going to give you some case examples that we have encountered so that you understand what I'm trying to say. So this is a 27-year-old. We were called to do a home visit because she had extremely challenging behavior or behavior of concerns. And when we actually visited the home, we noted that she had some abnormal involuntary movements. That means she was shaking her hands. She was also having incontinence and she was passing urine. So we decided to get some history from the caregivers, and we couldn't actually get any eyewitness who had witnessed any of these movements. So it falls to reason now to say, is this something that is typical for this person? Is this atypical? Does it happen in this child all the time, this person all the time? It calls for her going to be admitted to hospital to be able to identify whether she had epilepsy or not. But it also made it more difficult because of her behavior, where EEG was not something that they could perform, but MRI was done under sedation, and they picked up some changes in the brain, and that concluded that probably she had a very high likelihood of having epilepsy and started treatment. It also goes to show that people who don't have communication skills can present with some behavior changes or sleep disturbances. And this one, we were fortunate because the caregiver, who happened to be a domestic help, had actually taken a short video clip, and we recognized that she had epilepsy, and therefore she was further evaluated and had appropriate treatment. So you can understand why caregivers now say seizure burden is failure of recognition even before we go to establishing a diagnosis. If you don't recognize that the person has epilepsy, you'll never progress to be able to establish a diagnosis. And we all know, like the previous speakers who mentioned, that EEG, though it's the gold standard, may not actually pick up epilepsy. So you have to have all these processes in place. Do we have a good eyewitness? Who is the eyewitness? Can we actually get a detailed clinical history? How do we find out what is the trigger if I can't even express and tell you what the trigger is? How can I tell you I have an aura if I can't express and tell you what my aura is? So it becomes extremely challenging for the clinician as well to make an appropriate diagnosis, because it is the lens of the caregiver who actually brings out the history as well as the eyewitness episodes. But thankfully, we have telephones, we have hand phones nowadays, and so the phones are being used as an excellent mode, and that's what is being used in the centers. So if the training officers call you and say, I'm a bit concerned, the first thing we tell them is, why don't you take a video and send it to us? Because at least then we can proceed to say whether this is an epileptiform activity or not. The challenges in management then move on to, once you recognize, what medications do you use? There are not very many studies which are actually robust and performed in persons with intellectual disabilities. We do understand there's a high treatment resistance, which basically means despite starting them on a few medications, they may still continue to have epilepsy. How do we identify them? How do we know the efficacy of the medication? And how do we actually monitor the side effects? Because if they already have an existing behavioral problem and you have a mood disturbance that happens over and above it, are you going to say it's medication related, or are you going to say there's a person having some behavior changes? So it becomes extremely challenging. But all this can only be overcome by frequent communication and education. We also understand that there are few comorbidities that occur because they are prone to a higher incidence of falls and injuries. And I'm sure the training officers from the centers will identify this as one of the biggest problems, because a lot of them do have unstable gait, and once they fall, they actually have major morbidities. They can actually break their bones because they are sedentary lifestyle, they are not exposed to sunlight, so they all have a degree of thinning of the bones, and thereby they break their bones. There's also something called the SUDEP, which is otherwise called the sudden unexpected death in infancy, which tends to be slightly higher in persons with refractory seizures. And this is something that most families should be aware of and should be educated. I'm just going to run through about 2 or 3 slides on quality of life of survey. This is done by us, and this was actually done with the help of the Minds Care Circle to look at what actually our families in Singapore come up to say, this is really concerning for me. And we had 28 responses. I'm just picking out a few, and I've picked out the few where more than half of the respondents said they were extremely concerned about. One is achieving a care balance. Do you worry about a person having a seizure when he or she is out? And 50% of the respondents said yes. And do you worry being responsible for the person's injury or death? And 57% said yes. So you can understand the impact that this has on a family. And all this can only be overcome by education and frequent understanding. There should be a communication, two-way communication between your concerns to the clinician. And when this comes to you, when the clinician or your primary care physician tells you what are the ways in which you can look at it, this must again be translated to the training officers. Otherwise, you find that the caregivers who are in the daycare centers, who are looking after your loved ones, may not be able to understand what actually translates between you and the primary care physician. Understanding that you can do first aid management, and it's good to get accredited and do it in the appropriate way. Look at home injury prevention processes, which I think our OT, Mr. Mani, will be discussing later. True enough on drowning risks and what are the simple precautions that you can take. And also understanding a little bit about sudden death that happens with epilepsy. There are some monitoring apps that have come out, and it might be useful to try and pilot it out in Singapore. The next important aspect is the social compact and loss of independence. The person is unable to travel alone. You always need company of a caregiver. And this is something 57% of the respondents said that they were worried about. And this, again, is only with the help of support groups that you can overcome. Understanding that there's a care dependency, which means you can never leave them alone. I can't go on a holiday. It's a respite care service. What service do we have? And this is, again, 50% of the respondents mentioned about this. So there are some other ways to look at respite care. And I think these are some of the support services which will be mentioned later, but there are respite care services that you can think of and you can look at with the help of support groups. Personal skills, is it dangerous for a person to cross a road? And 68% said they need somebody to accompany. And again, this can only be overcome by looking at support groups and forming a network structure to help your loved one. So I'm just going to now pass on to Mr. Mani to be able to continue. What are the support structures that are currently available in Minds? Thank you.
Okay, thank you, Dr. Bhavani. Okay, hi. I'm just here just to bring you through some of the challenges and the support strategies, okay, especially for persons with intellectual disabilities, and how we can just support our trainers, caregivers, or volunteers who will be like attending to the persons with intellectual disability with epilepsy, okay, and what kind of challenges they are going through, and what are some of the support strategies we can just able to help them with in terms of education, in terms of providing training, or in terms of like collaterals that we can just able to like give, or you can just able to like educate the caregivers and volunteers and trainers in the centers to better support our clients in the center. Okay. I will bring you through the few points, okay. Some of the common triggers, factors of epilepsy in persons with intellectual disability disabilities and some kind of challenges they are faced by persons with intellectual disabilities in the centers, and some of the challenges faced by the caregivers, okay, at home or maybe in the community when they are bringing them out. And also just want to give a brief view on the how we can just do some psychoeducation for the training the staff in the centers and also the caregivers, and also a brief view about like some occupation therapy assessments and intervention, especially at the home environment. And lastly, I will just give some kind of resources that how the caregivers can able to tap on and help them in providing a better quality of life for persons with intellectual disabilities with epilepsy. I think that the previous speakers have gone through, there's a lot of triggering factors. Okay, I think they just already gone through, but I think some of the triggering factors, what I'm here just to highlight it over here, these are some of the triggering factors for the epilepsy, but especially for our persons with intellectual disability, what we can just see in the day-to-day in our centers. Okay, so we can see there's an extreme cold or heat. Okay, and for the person, for the females, okay, there's the menstruation during the menstruation, once a change in the hormonal levels. And also we have persons will have some kind of develop some kind of illnesses. Either it could be like a viral infections, or it could be some fever, or there could be some call us like a febrile fits. Okay, they will just get the kind of triggers, and we have also challenges with the caregivers and the clients. Okay, sometimes they will forget to take medications if they are prescribed with the medications. So which is also follow one of the triggering factors, which is commonly we can see in our clients with persons with intellectual disability. And we do have clients with have a lot of deprivation in sleep or lack of sleep, which also is one of the common factor which is highlighted by few of the speakers earlier. But and it is one of the comorbidities which is also very common in our persons with intellectual disabilities due to like other medical conditions or due to other mental health conditions what they has. Okay, and this is also one of the common cause. Okay, where they can have some triggers in the centers. And the clients also have some form of like a stress, or they have excitement over the activities or over the programs they participate in the center, or they're looking forward to do something interesting in the centers, or they have some fear, or they can have some to some extreme of some anxiety they have in terms of their participation of activities, or in participation when they are just having some social activities with volunteers and the kind of thing. So maybe some of these are the very common triggering factors that we can just able to see in our clients, especially for persons with intellectual disability in the center, or whenever we bring them for outings or for community participation activities. So we will see how these are the how we can just try to minimize some of these triggering factors in just better in better managing them. Okay, what are some of the challenges, okay, when the persons with intellectual disability face when they immediately they get fits? Okay, so what actually he or she may or may not experience the following things. Okay, the person whenever they have the fits, especially for persons with intellectual disability in the center, sometimes they will say either they may or may not respond to the voice or touch, or they may or may not aware of their own name or even the observer's name, especially who is a friend nearby and who is the training officers who attend to you and where they are, like a place and time. And also they may or may not remember actually what happened, because sometimes they will get they go into a stage of a bit confused immediately after the feats, or maybe they will be drowsy or the time, so they may not be able to remember what exactly they happened, and they may or may not be able to talk or communicate to the peers, or maybe to the colleagues, or maybe to the trainers. Okay, they have some kind of like a challenges on that, and they may or may not experiences. They have some weak or numbness in the body parts, and they have changes in the mood or behavior, and sometimes they get tired, or they may need to sleep. Okay, so maybe they will just feel very drowsy. They may just lie down after they just having the fits, and they will do it. And some other symptoms, which is including they may feel headache, and they may feel some upset in the stomach, or maybe they feel some kind of a pain or numbness in the body, that kind of things. So these are some of the challenges of what we see in the day-to-day when the persons with intellectual disabilities they will just experiences the challenges immediately. Okay, Then the intermediate challenges, what we can see over here is actually he or me or she may not experience the following things. That means if we say once after immediately having the fits, maybe what happens in the next 1 or 2 days. Okay, so maybe they will the clients in the centers, they may feel, oh, I may or not have the ability to participate in the activities. So maybe say, oh, the next day I feel very tired, I sick, maybe I may not able to come to the center, so I need to rest. So that's why it's one of the challenges. So maybe they're not able to participate the activities which is scheduled by the centers, or there's a program scheduled by the centers. They may not able to participate actively in that things. So that's one of the challenge. Then sometimes our clients after the fix, okay, they may also need a longer duration to recover after the episodes, because sometimes they may not able to immediately can return because due to other comorbidities they will have, or sometimes they have the behavioral challenges they have, okay, to do that, or maybe some other mental health concerns they have. So because of that, they may not able to recover very fast, okay, at sometimes. So may they need a longer duration, which is also one of the challenge that the caregivers facing, or also we face in the centers. And some clients also, they feels very guilty, okay, because after that, okay, say maybe I feel maybe the persons who saying, oh, so why other people are standing and looking around me and I'm having that. So they feel some kind of a guilty, and they may not able to easily socially, they may able to withdraw, they may not able to participate in their activities, okay. And they may also have develop some kind of a low self-esteem, so which will affect our clients in terms of proactively participate and just engage them in terms of their activities. So that's is actually is one of the challenges they just able to have in our center. Other than the intermediate challenges, we also feel the long-term challenges faced by the caregivers and the trained officers in the center. So one of the main challenges that the person is actually may face is actually they may not be able to participate in the outings, community participation activities, or maybe even overseas trips. So maybe we say this will prevent, there will be they have limited opportunities in terms of the community integration and outdoor social participation opportunities, because of the fix, they sometimes, the caregivers may not be able to bring them actively to all the outings and community participation activities. In the center also, they may have some challenges in able to bring them to outings. So, and also which also limited the gatherings with friends and family members. And this also will limit their leisure participation, which is including sports and games, because sometimes, they will find that, okay, the family will find that, oh, maybe there will be a risk involved in getting them to be participate in doing the sports and games. This one also will have some kind of limited employment opportunities, because they feels that, okay, there will be a lot of times the clients may able to face some kind of a risk behaviors when they are in the community or in the employment. So which also limiting the opportunities given to them in terms of the employment, especially the persons will have an intellectual disability together with epilepsy. Okay, and also it will have some kind of opportunities for them to deprive from just to get into the community actively, okay, on a regular basis. And we also have experienced the challenges. Okay, the clients also have absent from the centers or program quite frequently. Either they may have the frequency of the fits is more higher for them, so the caregivers not able to send them to the center regularly, so they ask them to rest at the home, or maybe they need to even to go for more hospital visits or for the clinic visits for them for review, or even the client may be having those who are having a refractory epilepsy, or maybe to more high frequency of the fits, they may even to get them to be hospitalized, and maybe even to stay in the hospital for a longer period of times, okay, to get them to get reviewed about the medications, or get them to get adjusted to the new medications or kind of things. So this also will one of the challenges that in the center we face. So they may not be able to attend the centers on a very regular basis, and they have more frequent absent from the centers or from the programs. Okay, let's move on to what are some of the challenges which is faced by the caregivers. Okay, the caregivers actually face a bit more challenging in terms of bringing them for more actively in the outdoor activities, so which also limit the social engagement of our clients, okay, in the day-to-day life. Okay, and also they also face challenges in terms of support from other family members, because they say in terms of a caregiving for persons with intellectual disability with fits or maybe with epilepsy is a very long-term process, and it is need a lot of support from other family members. But sometimes they find that not all other family members are very supportive, and they, or maybe due to their work commitments, or maybe due to the other commitments what they have into the social participation activities. So maybe there is a lack of support from other family members. And they are also having a difficulties in engaging siblings in the care. But if you say they have other siblings in the care, they may be the siblings may be not able to have a very good understanding about the client's fits in the family, and maybe they also try to when the parents try to engage them in the care, but I think the parents also facing difficulties to engage the other siblings in the care for the persons with intellectual disability with epilepsy. And they also facing a very high challenge in terms of administering the medications, okay, for them. So while you're giving the medications to them, it will be quite challenging for some of the caregivers to administer the medicines on time, on a very regular basis, or even to follow up on with the medical aspects in a very regular basis to get the medications to administer the medications very properly, yeah, at home. So that's another challenges also faced by the caregivers. And they also face a very high level of stress, anxiety, and depression. I think which are some highlighted by some of the speakers earlier. And definitely, okay, the caregivers caregiving stress is really very high for persons with intellectual disability with epilepsy, and they may even go into stage of a lot of anxiety, and they may even have some caregivers even they go into depressions. Okay, and the another challenges faced by the caregivers is actually the sleep disturbances and sleep deprivations, because quite number of our clients they do have epilepsy during sleep. So whenever they have the sleep during sleep, whenever the person's having the epilepsy, so maybe of course the caregivers has to wake up and they have to attend to them and see what's happening, and they try to monitor the situation. So which is also affect the sleep of the caregivers who will be providing the care to them. So this is also another challenges which is provided by faced by the caregivers, and they have easily, with all the above mentioned challenges, the clients the caregivers may have some kind of burnout, and they also face some kind of financial constraints, okay, especially when they need to go for more frequent and regular hospital visits, and especially for medications. And whenever there is a change in the medications, especially recent days, there will be a lot of updating of the newer medications, which definitely which will be a bit more expensive than what they will be happening in the in the past. So maybe I think when there is a time they need to go for bring the clients for regular medical checkup, they need to go for more investigations, more new terms of medications, okay, they may also face some kind of a financial constraints. And it is not only that, I think they also sometimes they need to send and the clients fetch the clients from the center using private transport, because sometimes they may not able to take public transport because of they having the higher incidence of fits, and they are not safe in traveling the public transport. So maybe sometimes the caregivers need to take like a book their the Grab, or they had a private transport. So which is also add on another financial burden to the family in providing the care to the clients while they are just rendering the service. They also face some challenges in the work-life balance, because sometimes the clients who are having the epilepsy in the center, so sometimes what we do is we need to call them, and maybe they need to rush back from the office to come and to either to pick them up from the center, or even they will come and bring them to go for a medical checkup, that kind of things. So I think there is a lot of sometimes the disruptions happens, or maybe if the caregivers need to take maybe more frequent leave the workplace to attend to the medical needs when the clients having a more frequent form of like epilepsy and for the medical consultation. So whenever there is a kind of things, okay, there's definitely the caregivers, the work-life balance will be like a bit affected. Okay, let's talk about some of the support strategies. Okay, what are the things that we can just say in minds? We help the clients and we help the caregivers to overcome some of these challenges and to have a better quality of life in the center and in the community and at home. Okay, I think some of these are the support strategies what like practically in the day to day we do in the center. Okay, and these are the real strategies what we have done in the center, and I just want to share some of these strategies how we are just able to better help the staff caregivers in providing a better care or a good quality of care for persons with intellectual disabilities with epilepsy. I think the first thing is actually we provide like a psychoeducation for the staffs and caregivers, and we also like provide like kind of a basic first aid education and understandings of what the do's and don'ts for the caregivers and also for the staffs. And we also test to monitor all the episodes of the epilepsy, what is happened for the clients in the centers and at home. And we also just to do a lot of safety education and tips on the day-to-day activities and how the clients can be a better managed at home and the centers and in the community. Okay, I think one of the strategies that we will just use these things is actually we will develop this kind of epilepsy first aid poster, and this is actually is a very good visual reference resources for caregivers, parents, siblings, or even for the helper who will be at home who can able to like provide some kind of a care to for the persons with intellectual disabilities. So this is actually is a very visually prepared with all the different common steps that the key points that how we can just able to support the persons with intellectual disability whenever they're having the fits. So which is including, they say, oh, they must keep and calm or stay calm and ensure the client is more comfortable whenever they're having the fits. And we will try to protect the head or put something soft under the client's head. And we try to note down the length of the seizures. Okay, I mean, what is the duration that the person is having the fits. And we try to call ambulance. Okay, 995, the seizure lasts more than 5 minutes. And we also try to encourage them and keep the onlookers away, because this is also something we can just see in our center, because whenever they're having the fits, people just to crowd them and stay nearby and see what is going on, because our clients are persons with intellectual, they are very keen to know what is happening or those things. So maybe they try to gather around it happens, or even whenever in the community when it happens, we will try to them, okay, we try to keep them to be on the course survey. And we also try to educate them and do not give any food or drink until they are fully stabilized, because this is something very basic education we need to tell our trainers and also our volunteers, because sometimes they are very panic. Maybe they find that the person is really tired, or maybe these things, so maybe you look, so they I think it's more on the very compassionate ground. They will just try to go and give some water, or they will try to give, so we try to tell them not to give any food or any drink until they are getting fully stabilized. And as I think the doctor mentioned before, I think we try not to put anything in the mouth, because I think this is another became another risk for the client, and they may even able to can go into the person is having a very high level of biting the tongue, or they even have the bite the object what you just try to put in the mouth. Okay, and they may even they swallow, or they can become a choking hazard for the person. I think this is actually one of the in the past, I think one of our client they had this experience. Okay, I think it's a very some of the traditional cultures also, they try to put the spoon in the mouth to prevent the tongue biting, and actually the person is actually bite and is big, and this actually the head of the spoon is already broken, and the person tried the swallow, and is actually go and stuck into that, and we brought to the hospital immediately. And to that, actually the caregiver done it very unknowingly, because the caregiver experiences the fits for the first time in the life. Okay, at the age of 21 years of the clients. Okay, so that's the things, because the caregivers are very panicked, they don't know what to do, they just end up doing. So it may create a situation unnecessarily to escalate to kind of a more health complications, or maybe more health kind of like a risk in time. So maybe we will try to educate them all these things to the caregivers, and also our trainers and volunteers who will be there to that. And we will tell them if you say the client's having any means if you say they're trying in the after the fits the person is like recovering, we will try to put them in the recovery position. So we will also try to educate the caregivers and the volunteers and the staffs and centers how you can put them in a recovery position. Okay, what are some of the common practices in mind centers that we will do is actually, what we'll do is actually for every clients, okay, we try to maintain a file with the client's details and the seizure management, okay, and we regularly update the client, the epilepsy diary for clients with the frequent seizures. So there is a epilepsy diary for each clients, or there will be epilepsy chart for each client. So where they will be just the training officers will usually chart every episodes of the fits, okay, what they'll be having in there. And we also in the as a practice, we for the safety purpose, we also encourage the clients to sit on the chairs with armrest, okay, during activities and meals, because this will help them to reduce the risk of falls when they're having the fits, or even with the minor epilepsy when they're having during the while they are sitting and doing some activities. And we also try to activate the allied health professionals who will be presenting in the center to assist in the case of seizures, because we do have like physiotherapists, occupation therapists, we have social workers, like a psychologists, all things. So we also try to get the help, okay, whenever the client's having fits, to attend to them. Maybe we see can able to like a better assist them in minds. Okay, in addition to that, okay, we also help them to whenever, because our centers will having a lot of training units because it's like a classrooms, okay. So sometimes the clients will move from one unit to another unit, or transfer from one class to another class. So whenever they will be having this kind of a transfers between training units, or we'll transfer from one center to another centers, so there will be a very detailed history of the epilepsy of the particular client will be given to the staff, okay, during the handover. So there will be a proper briefing, which is including, okay, what is the frequency of the epilepsy the person is having, what are the triggers the person is having, and how they can better manage, and how what is the regular follow-up they will be taking, what kind of medication they are taking. So they will be just give all this kind of like a regular updates when they are doing their transfers between the units, or when they transfer between the centers. And the training officers always like encouraged to get regular updates from the caregivers after every hospital review. So when the caregivers bring them to the hospital, okay, for a regular checkup, okay, for every 6 months once, or every 4 months once, and we will try to get the updates from the caregivers, okay, what was the follow-up done during the last visit, okay, was there any change in the medication, was there any change in the dosage of the medication, or is it change in any the time of providing the medications. So we'll try to get all these updates from the caregivers and keep the record for us to just to know, so that we can just able to like get better aware of the clients. This we can just able to do it manage in the centers. And for every training units, we also try to equip them with a small pillow and a small mattress, or just a yoga mat, especially for persons with having like a clients with the frequent fits, seizures, because I think this is actually help them whenever they use the fits. We can just able to like have make them to have a good recovery positions, which is using this. And we try to avoid triggers if known. Okay, especially only if the triggers are known, we try to avoid the triggers. But sometimes, okay, we really don't know what is the triggers. I think the triggers are really not very clearly known. Then we may not able to help them. But if the triggers is really known to us, maybe it's from the caregivers, or over a period of time, we try to understand that, okay, maybe these are some of the common triggers that will help them to avoid. Then we try to avoid from the centers. And we also try to note down the timing and the duration of the seizures, and this will be like a note down in the epilepsy diary. Okay, some of the things what we can do during the home visits, we will try to educate the help caregivers to in terms of like safety education. We will try to do some kind of like a safety educations while sleeping. Just remove the sharp objects or potential dangerous objects near the bed, and sleep as on your lowered bed if there is a risk of falls, and have someone can assist in the event when the users are nearby, maybe the caregivers. And kitchen safety, okay, we try to encourage them to use a microwave as much as possible, but not the open flame, okay. And we try to use like more of encourage them to use like a non-breakable dishes, and we use cautions with hot liquids and fruits. And we also try to accompany persons intellectually with epilepsy when they are cooking. So do like a buddy system. Some kind of a recreation tips. Okay, we will just try to in the center, and also we'll encourage the caregivers to have a buddy system all the time, and try to encourage have a more frequent breaks and drink more water, and try to wear like more protective clothing, which is like helmets, elbow and knee pad, all these things. And try to take a shower instead of a bath, because I think the research shows that the bathtub drowning is one of the common cause of the accidental death for persons with epilepsy. So maybe whenever they go for like a holidays, all those things, okay, not to have the use like a bathtub unattended, or maybe try to use more like a shower instead of a bath. Okay, and try to carry a medical alert card or any card that can have some kind of a medical information state that, oh, this is a person with epilepsy. So whenever there is a person in the public, or maybe a volunteers who will be attending to them or anything, they know, oh, he's a person with epilepsy. So maybe at least they can know aware of the conditions. And some support strategies, what the occupation therapists we will do is actually we will carry a home safety assessment to assess the potential hazards, okay, for persons with intellectual disabilities and with fits at home. And we try to recommend home modifications and some adaptations and assistive tools, okay, to encourage the safety of the clients. And some common environmental and home safety, which we always have, is actually we try to pad the hard edges of the furnitures and the tools they have, because I think this is one of the things whenever there is a risk of falls, they may go and hit against the edges of the tables. So maybe we'll try to put some kind of like a pad it, and so that maybe in case it won't hit any kind of like even though they will hit, it won't be like a very hard effect on that. Keep walkways and the floors clear of cords, tools and materials. And we try to encourage persons with intellectual disability to sit on a sofa or a chair with armrests during activities, to also to prevent the risk of falls whenever they will having the fits. And we will try to accommodate the persons when they're having the kitchen appliances, while they're using the kitchen appliances, and especially with the power tools. And this is something which is what we are using in the center as a gear here as a personal protective equipment to prevent provide some kind of like a protection to the head whenever they have a risk of falls. And these are some of the assistive and adaptive equipments. Okay, we have non-skid mats, or we have some grab bars and all those things. Okay, and chairs with armrests, which can able to help the persons with intellectual disability, the fits, okay, for the safety aspects. Okay, just a touch base on the employment for persons with intellectual disabilities with epilepsy. And these are some of the employers' concerns when they are having in the community. The employers have a concerns, okay, the persons with intellectual disability with epilepsy, they may have an concern of they have increased sick leave, or the person may have the increased potential for accidents or occupational health and safety issues, or the person may have a lower productivity, or the employer may need even to pay a higher compensation insurance premium because of the risk of the health risk, or sometimes they have some attitudes of the colleagues, the co-workers about towards the person's intellectual disability fits they are working in the employment. And also they say, the employers also say, oh, they need to educate the staff about this the condition and how they can able to like a better manage in case of when they're having fits. And this is one of the collaterals that we have developed in minds, okay, to support the employers, okay, to provide a caregiver, employers education, and also to educate the co-workers and the colleagues in the employment, okay. So see, in case of fits, okay, what they're supposed to do, what they cannot do, and how they can able to better manage the conditions when they will do that. So this is one of the supporting the collaterals that we develop from minds, and we just educate the employers. And some of the resources that what I had over here, I just want to share in a nutshell. I just want to put everything together. These are all some of the resources that the caregivers and the trainers, or persons who want to support the persons with intellectual disabilities and fits, okay, they can use all these resources. I think earlier I shared about the epilepsy posters. The epilepsy posters is probably a very quick and pictorial reference on do's and don'ts for caregivers and trainers. And we do have epilepsy brochures, and this provide more information about the epilepsy and first aid management for employees and co-workers. Okay, and we have epilepsy diary. This is actually helps to track all the history and different episodes for caregivers and trainers. So they can be a diary. They can able to note down every single episodes, and they can bring it to the doctor for review. And we do have an assistive technology fund. And this fund is actually the one who help the caregivers to provide some subsidy to get an assistive technology devices, or they give some adaptations so they can able to do at home, which is like shown earlier. When I want to buy a headgear, or they want to modify the home environment, they can able to tap this assistive technology fund, which is administered by the SG Enable. And we do have an epilepsy care group Singapore. Okay, this is a support group. Okay, they can able to provide like a counseling, and they also provide like support groups for caregivers for persons with intellectual disabilities and epilepsy, and also they do a lot of community educations. And Minds, we have a Minds Care Circle. Okay, this is actually is a support network for the caregivers. This will provide some updates on usually on the latest news and specialized resources and courses and workshops, what we can just do. So this is another platform where the caregivers can use it to just to have for more of education. And on top of that, we have a Facebook group. Okay, I think we identify this Facebook group called Singapore Caregivers Epilepsy Seizures Global Developmental Delay. So this is a Facebook group in you can just able to search, and this actually is a sharing and they discuss on anything related to the on the all the points which is above, and it's mostly like it's a support networks. They can able to share the experiences, they can share what can be done, and they can give some kind of like a support networks for them to do that kind of things. So in a nutshell, okay, these are all the various resources. Okay, the persons I mean say either the caregivers or even the public or maybe whoever want to support a person with epilepsy. Okay, even either some of the resources, or even not necessarily to be can applicable only for a person with intellectual disability and epilepsy, and some courses are very general and some resources are very general. I think they can able to like pick up the resources, the necessary resources as and when needed, or what would be the like common resources they can just able to use, and they can tap on to just to provide a better quality of care and education for them in the community. Okay, these are some of the collaterals which I just mentioned earlier. Okay, you can see there's a first aid poster there, and you can see there is a copy of the epilepsy diary there. Okay, and you can see the collaterals for the pamphlets for the for the epilepsy education for the employment side, and you can see there is an assistive technology fund. Okay, this is actually you can able to search and see whether you are eligible for this fund and what are the things you can able to buy from this fund. Okay, there is it's about like nearly 90% of the equipments or the home modification supplies all subsidized. Okay, with that, but there will be some eligibility criteria for it. I think you can approach SG Enable if you are really need to do that. I think there's the Minds Care Circle, and we have this epilepsy care group for the caregivers, which I just shared earlier. This is the Facebook group, and we have the Epilepsy Care Group Singapore, which is already, as I mentioned, which is able to provide some kind of counseling support and support networks for the persons, for the caregivers. Yeah. Okay. Thank you. Thank you for your attention.
Thank you so much, Dr. Bhavani and Mr. Mani, for sharing and joining us earlier on. But there are a few questions from our participants, and I think they're coming in fast and furious. Yeah. Okay. So perhaps I think for Dr. Bhavani, you did mention earlier on in your sharing about some of the monitoring devices that has been since made available in the market. Would you like to share a little bit more about these monitoring devices?
Okay, so I think there are different aspects that we need to look at monitoring devices. One is actually monitoring the epilepsy itself. That means, do you actually identify this person has had a seizure? And the other one is monitoring how frequency you get by using digital apps, like what Mani was saying, maintaining a diary, but maintaining digital apps to monitor. So let's go on to monitoring epilepsy. That means, how do you know a person actually has got a epilepsy? Can you actually preempt and identify? Because that is going to be very relevant to our population who may or may not be able to communicate that they have an aura. So there are many in the market. And I think if you actually look at all the monitoring devices, the principles are basically based on physiological changes that happen in your body. That means when you have a seizure, you probably will have a higher heart rate, or you'll have a lower heart rate. You'll have something that triggers in your body, and it actually picks up these signals, and then it says, okay, that means you've got a potential for developing. That is preempting a trigger. And the other one is, of course, having the seizure itself, and then later on you go back and say, okay, this was a seizure episode. Unfortunately, I don't think we have anything greatly validated for persons with intellectual disability, and none of the tools that we can strongly advocate at this point in time. A lot of the devices are currently being researched. A lot of the devices, because you also need to, when you give it to a family, you need to be 100% sure that it's going to do what it's supposed to do. So I think we are at a stage where a number of appliances are coming, and we hope that we can get more research studies that can be more validated to people with intellectual disability so that we can roll it out in the market. So I think that's one.
Thank you. And I think with all the sharing of the good work that Minds have done for the community and throughout our country, how is it that are we able to help persons with intellectual disability with epilepsy be more independent in their day-to-day?
So I think for caregivers, the most relevant thing is first identifying what are the areas of independence you want to achieve, because independence can vary all the way from activities of daily living to independent travel to be able to successfully be employed in the community. So it's a wide range of independence, right? So if you can identify trigger factors, then it makes it so much more easier, because then at least you know these trigger factors can be avoided. Two is to make sure that actually the epileptic episodes are not frequent, because then if you can control the epilepsy to a large extent, at least to a large extent, you can make the person independent. The more frequent and unpredictable the seizures are, the more caution that you have to exercise even for doing your daily activities and living skills. The third and the most important thing is communication skills should be improved for a person with intellectual disability, because we do understand that communication doesn't have to be necessarily verbal all the time. It can be gestures, it can be pointing, it can be facial expressions, it can be writing something quickly to indicate I'm not feeling well. So the more often you can get them to express their needs, then it also becomes easier for us to understand, okay, this person is not really feeling well today. Maybe I should avoid these things. So I think communication skills, including the person in as much as possible to their cognitive ability, to the level they can understand in making plans, so that at least you give them that level of independence. What is it that I want, rather than what is it that you want the person to do? So if I want to do something independently, how can I achieve that? How can I do it on my own? How can I get support groups to help me? How can I have a buddy system? So I think it's first very, very important to kind of work on separate goals. It is a difficult balance, but it is not something that you can't achieve.
I agree with whatever you said. It's such important. It's very crucial to actually address all these basic things first before we actually get to the bottom of what was asked earlier. Perhaps now let me just route some questions to Mr. Mani. You mentioned about the occupational therapy and some of the sensory help, in your slides earlier in your sharing. So, what sort of OT or rather sensory help will be suitable for persons with epilepsy?
I think there should be we need to identify there could be some triggers, okay, which may cause there's some kind of posing some kind of a sensory challenges, which is they can also be a risk of causing like epilepsy. For example, we do have clients with having a photosensitivity. We have a triggers which is having a loud noises. So these are some kind of like a sensory things that they can able to do, or maybe they can able to feel some kind of unusual sensations. They can just able to do it. I think when you see the kind of some kind of like a triggers, if you say related to the sensory systems, and we try to avoid those kind of triggers. Okay, I think persons with intellectual disabilities, I think in the centers, we do have clients who can get fits by triggered by very loud noises. And we do have clients who can able to have some kind of a photosensitivity triggers with when the client's watching an iPad, and we see there is some kind of like a flickering lights going on, or there will be a frequent changing of the screens is going on, or they couldn't able to like adjust to that kind of a sensory stimulus. Okay, though maybe it can be a cause that can able to do that. So I think maybe we see whether there could be some of the triggers that can be some kind of a sensory challenges, and we'll try to educate them to that to the caregivers or even to the trainers maybe we'll say, or what could be a substitute activities that we can able to give for that, or maybe how we can just able to like a better provide like a support whenever the person is really can't able to put them into a very high sensory need of an environment. For example, if you say there is an activity going on which is reading, playing a loud music or loud noises or the kind of a things. Okay, so what could be some of the things we can able to have? Either the person is able to provide with the earmuff or something, or we can just able to like provide the person to just to a calmer environment for them to just to better to cope up with the kind of things. So I think it will depends on how I mean what because it's not like a one challenges they will be have. I think there will be few on different sensory systems. Okay, they do have, and if that particular systems is really causing a kind of a triggers and can do that, and either we try to avoid or we try to just to accommodate them with other means. Yeah.
Thank you. All right, so I'll take one last question, and the rest of the questions that have been asked by the participants, we'll try to address them offline and actually collate them and send it back via an emailing list for all those participants who have registered with us. So the last question would be on the support strategies that I'd like to comment some of the questions into one on how do you actually try to educate the public, or rather the caregivers taking care of persons with disability and epilepsy, on proper caregiver training in terms of keeping their patients or their loved ones safe when they are experiencing a seizure. Are there such trainings, caregiver trainings available for this group of families? Yes, in the community from my.
I think for definitely for persons with intellectual disabilities, I think what in minds in minds level, we do have organized like a regular workshops and seminars, and for to try to educate the caregivers, okay, to provide the kind of like a training, how to just to care for the persons with intellectual disabilities with feeds and the kind of things. The second part is actually we also like provide a lot of trainings through like a home therapy kind of things, or maybe home visits. So what we do, as I mentioned, we will as an OT, we will just also do a lot of home visits, and we try to educate the caregivers in terms of like providing suggest some kind of home modifications and home adaptations. We tell them why it is important and how it is going to benefit for the persons with intellectual disabilities, epilepsy, the kind of things. I think in the larger scale, I think there are organizations which I highlighted earlier. They have like Epilepsy Care Group Singapore, and there will be other organizations. Definitely, they do have a lot of community educations things they going on to do that. And minds, we also will take whenever we will opportunities when we try to reach out to the community. For example, as I mentioned, whenever we want to reach out to the employers, okay, we will try to educate all the employers. We try to educate the co-workers, and through this kind of like different resources what we have, and also we will try to have some sessions with them. If the employers is willing to, then we will just try to educate them to just to give the kind of a talk, okay, how much the persons with the intellectual disabilities, okay, or with epilepsy can be benefit from the employment, and how as a minds we can also can come and support them in terms of doing to provide the kind of support to help them into the care kind of things. Definitely, okay, there are various platforms. Okay, I think we have like a lot of social networks will be going on to share their experiences, to share that kind of like a community education groups will be going on. And on top of that, I think as I shared earlier, there's a lot of resources that we're trying to develop, and we're trying to advocate to just to reach out to the public and reach out to the caregivers, okay, through all these means to have more understandings and to get more acceptance, okay, of the persons with intellectual disabilities and epilepsy, to better integrate them into the community.
Thank you so much, Mr. Mani and Dr. Bhavani, for really joining us today. Yes, to top it off, I just wanted to clarify that we will email the responses to all the questions that are not answered via email. Yes, all the questions. We'll try our best. Okay, so thank you so much again, Dr. Bhavani and also Mr. Mani, for joining us today. Before we end the public forum, we would like to invite Dr. Chewy Rong to actually give us a closing address. Dr. Chew, please.
Hi, thank you. So as we come to the close of this forum, I would like to express my deepest gratitude to each and every one of you who has contributed to make this to making this initiative a success. So together, we have taken a significant strides in raising awareness about epilepsy, dispelling some of the myths, and fostering a more inclusive and supportive environment for those living with this condition. So as we move forward, let's continue to be advocates for epilepsy awareness and education in our communities, and to strive to create a world where those living with epilepsy are fully supported and embraced as well. Thank you. 不知不觉就来到了今天我们这个论坛的尾声了哈，所以希望今天大家对于癫痫症有多一点的了解，少一点的误解。癫痫症本身并不可怕，可怕的是如果我们对它产生太多不了解，从而有更多的恐惧的话呢，就会有歧视和羞辱的出现。所以希望呢，从今以后我们可以对于癫痫症有更加的了解，然后从而为有癫痫症的病患者呢有一个更好更安全的一个环境，让他们跟我们共存，并且乐观的面对生活。谢谢。
Thank you, Dr. Xu. So we have come to the end of the public forum, and on behalf of National Neuroscience Institute and the organizing committee, we thank all the speakers for their insightful sharing today. A very big thank you to all of you, our participants who tuned in and spent your precious Saturday morning with us. Do help us to actually scan the QR code and provide us with your feedback so that we can improve on any shortcomings for our future webinars. So till we meet again, and do have a wonderful weekend ahead. Thank you.